Okay, I'm going to get us started. Welcome, everybody, to the February 2024 Health Equity, National Urban League Health Equity webinar series. I am Dr. Lydia, the Vice President of Health Equity and Policy here at the National Urban League. I'm very excited to have everyone with us and to have this esteemed panel. I'm just going to do very quick introductions, but I'm going to let them introduce themselves. But, you know, a lot of you, I do a lot of these panels, and a lot of you know that I always have a rhyme and reason behind why I do stuff. And so I'm really excited about the folks that I have with me on this panel, because they're going to give you a broad breadth of knowledge about different things in heart health, including research, including medicine, you know, preventive care, and about our diaspora as African Americans and Black Americans here in the US. And so I'm going to start with just whoever is the closest to me. And Dr. Sharon Smith happens to be right to my left. She works at the National Institutes of Health, which we know is our preeminent research organization. And she is the project officer for the Jackson Heart Study, which she will talk about a little bit later. Dr. Yvonne Commodore Mensah is an associate professor. I saw that and I'm very excited for her promotion at the School of Nursing at Johns Hopkins University. And Dr. Martha Gulati is a professor of cardiology at Cedars-Sinai Medical Center in California. And so I am going to let them introduce themselves and talk a little bit more about what they're doing, but we're celebrating heart health this month, which is very important. As we know, it's the #1 cause of death for anyone in the United States, and it doesn't get as much attention as some other things that are more high profile. And so we just want to make sure we bring your attention. So I'm actually going to start with Dr. Gulati, and just tell us a little bit about your field, because Dr. Gulati is a little different in that she does preventive cardiology. And so I want you to explain to people what preventive cardiology is, and why is it that that's the field that you chose to go into?
Yeah, so thank you for having me here. It's such an honor. I am a cardiologist at Cedars-Sinai, and I'm the director of preventive cardiology. I predominantly focus on women, but I also focus on men too. And the reason that I went into preventive cardiology is because 80% of heart disease is actually preventable. The problem is we do such a terrible job actually at probably all measures of prevention, but specifically for heart disease. There's so much, I apologize, my dogs are in the same room. I think that there's so many things we can do, but people need to be equipped with the information to make those changes and to know if they're even at risk for heart disease. And again, heart disease is so common. And many of the risk factors also are incredibly common. But as you already said, heart disease is the leading killer of both men and women in the United States. Just to put it in perspective, I mean, for women specifically, over 400,000 women a year die from heart disease. But just a little bit of over 40,000 women die from breast cancer. Women tend to know that they're at risk for breast cancer. They tend to not know if they're even at risk for heart disease. And it's not to belittle breast cancer. My only point is that we should know if we're at risk for heart disease, and we should be proactive about preventing it, just like any other disorder.
Thank you so much for that. And that you actually just gave me the numbers. Like I always use the breast cancer cardiovascular disease example, because everybody is scared of breast cancer, and not that it's not something you should be scared of, but the magnitude for people who die of heart disease is so much larger. And so I do appreciate you giving us that magnitude. Sharon, can you tell us, Dr. Smith, I should say, Sharon's a friend, so I'm calling her Sharon, but it should be Dr. Smith. Can you tell us a little bit about the Jackson Heart Study and why it's so important, and particularly important for the cardiovascular health and well-being of Black Americans?
Good morning, everyone. Thank you for the invitation. I am the program officer for the Jackson Heart Study, and the Jackson Heart Study is a cohort study that examines the causes of the disproportionate burden of disease, of cardiovascular disease in African Americans, and specifically in Jackson, Mississippi. It was started in 1999, and Jackson, Mississippi was chosen because of the high numbers of cardiovascular disease and cardiovascular disease risk factors in that area. And so the primary objectives have been to look and to understand the causes of this extreme burden so that then eventually we'd be able to reduce risk of cardiovascular disease going forward. And really it's important because as you think about life and extending life, you want those to be good years, right? You want them to be healthy years, and cardiovascular disease is something that is such a it touches so many people. And like Dr. Gulati just said, so much of it's preventable that you want to live a long life, but you want to have a good quality of life. And so that's one of the reasons that it's really important to understand some of these factors and then to be able to adjust some of them as you can. I do want to say a couple of more things. The Jackson Heart Study is the cohort study, but it also includes a couple of other components. We have a community engagement center that conducts community health health promotion activities in the Jackson region. And we also have 3 training and educational centers. There's one that's an undergraduate program, and we have 2 graduate programs. And those are to help diversify and train the future scientific workforce. And so I just wanted to mention those things. I didn't want you to leave just thinking we were just a cohort study.
Dr. Smith, thank you. And I'm going to go a little further as we get into discussion about the importance of Jackson. But I do want to get to Dr. Commodore Mensah to talk to us about her research and the work that she's been doing in not only African-American community, but African diasporic communities.
So good afternoon, good morning, everyone. I'd like to first thank the National Urban League for the opportunity to have this conversation in February, which is Heart Month and Black History Month. So it is one of my favorite months of the year because I get to talk about heart health and all the things we can do to promote heart health. So I'm Yvonne Commodore Mensah. I'm an associate professor at Johns Hopkins School of Nursing and Public Health. I'm also faculty at our Center for Health Equity. So I'm a nurse by training, but I'm also a cardiovascular disease epidemiologist, meaning that I study heart disease, but I have a particular interest in how we can take the knowledge that we have about evidence-based strategies to promote heart health and implement them in community-based settings. So I recall that when I was working as a nurse on a cardiac floor, and I took care of patients with heart failure and different conditions, most of the patients were Black, and those who were readmitted on a fairly frequent basis were often Black people and people of color. So it made me really curious about some of the reasons for these disparities in cardiovascular outcomes. And so I decided to pursue my doctorate in at the Johns Hopkins School of Nursing. But when I started my PhD and I took a cardiovascular disease epidemiology course, almost every week when we talked about heart disease, whether it was hypertension, diabetes, kidney disease, I kept hearing over and over again, Black people are more likely to have this. You name it, any condition that was talked about, Black people were more likely to have that condition. But what was really missing from that conversation is sort of why. Because it made me wonder if I was bound to develop hypertension, diabetes because of my skin color. And then, I learned that unfortunately we use skin color as a proxy for race in research, but by doing so too, we overlook the heterogeneity in the Black population in the US. So it's important to highlight Black versus white disparities in cardiovascular health. But it's also important to understand that there is heterogeneity or differences within the Black population, particularly in foreign-born immigrant population. So I'm happy to speak more about that, but I realize that I'm breaking up a bit, so I'm going to switch devices if necessary. So thank you so much.
You're not breaking up, you're good. Don't worry about it. We can hear you clearly. So I think I want to, you all gave a wonderful overview of kind of the work that you do, but why is it so important? I think Dr. Mensah, Commodore Mensah, you really just kind of led us into why is it so important for us to talk about heart health during Black History Month for Black populations, you know, and if you want to kind of expand on what you've been talking about, of if this month in particular for Black populations, as you just said, highest risk of cardiovascular disease, highest risk of diabetes, highest risk of hypertension. So really, all of these are leading factors to heart attacks, to having cardiovascular disease. Why is that so important for us to be concerned about that?
So on a number of levels, starting with why Black people need to be aware of this risk. And Dr. Isaac, you alluded to the fact that, or actually, I think it was Dr. Gulati as well, who alluded to the fact that, unfortunately, in terms of our perception, people may perceive that cancer is the disease that they should be most worried about. But we're also learning that, unfortunately, people may not be aware of their risk for heart disease in terms of having hypertension or the relationship between, for instance, obesity and hypertension, obesity and cardiovascular disease. So increasing awareness. And I've had this experience in the community where we screen people for cardiovascular disease risk factors. We often go to churches. We screen them for hypertension, high cholesterol. We use point of care testing where with just a drop of blood, we can provide someone their full lipid profile. And then we have conversations with people about their knowledge or awareness of their risk factors. And we found that there are people who may not know the difference between good cholesterol and bad cholesterol and the things that they can do in terms of lifestyle. There are people who've been shocked to learn that if you have obesity and you lose weight, it can actually help to bring down your blood pressure. But if you also are active and get more exercise, so exercise is medicine, food is medicine. These are some of the messages that we drive that we promote at the community level to encourage people to take their medications that's prescribed by cardiologists and clinicians, but also empower them to take charge of their health by being more active, by eating healthier diets, but also getting more sleep. We'll get into that too, because unfortunately, not having enough sleep is also linked with poor heart health. Apart from making sure people are aware, clinicians as well, healthcare providers, and Dr. Smith alluded to the fact that we need to diversify the health workforce. We also need to work together to treat people appropriately. There are instances where people may have high blood pressure, but their blood pressure is not controlled appropriately. They're not on the right number of medications. Their medication is not changed if blood pressure control is not achieved. So those are the two that I'll highlight, but I'll turn it over to my colleagues.
I think those are such great points. And I do a lot of work on sex differences and how we, have a lot of bias. Actually, it's not even about our biological sex. It's truly about the gender bias we have in the United States and actually around the world in terms of putting men's health first and not women's health. But every time I talk about that, I always give them another piece of information. I always say, wherever I say women, you can replace people from diverse backgrounds, because the truth is where we find disparities, where we get to make judgment calls, or we get to, I don't know, just decide I'm going to treat somebody this way and I'm not going to treat someone that way, where women have these barriers just by being a woman, or chest pain is taken less seriously. People of diverse backgrounds also have the same. And I always say it's worse to be a woman, but truthfully, it's worse to be a Black woman. And of all groups, whether we talk Black men, white men, white women, Black women, it is the Black race particularly, but Black women who actually their health, their risk factors don't get addressed, and including their symptoms when they present with symptoms. For example, I do a lot of work on chest pain, and if you present with chest pain to the emergency room, they'll have a longer time to be evaluated. Women and people of color, they are less likely to get an EKG or get some cardiac monitoring. They'll be less likely to be seen by a cardiologist. So the ER may not call us to come down and see them, and they're less likely to be admitted to the hospital, even when they present with the exact same symptom. I mean, I know I could talk about the differences in how women might present, but same symptom, women and people of color do not get treated the same way. So we have a lot to do. And I love that both Sharon and Yvonne, you both mentioned how we need to diversify medicine in every aspect. I will say in cardiology more than any other specialty, because the disease is so common. And yet in terms of our representation, it's less than 3% of cardiologists that are from diverse backgrounds, whether we talk Black or Latino. And so and women is only 13, or I think we're 14% now. It's grown in the last 20 years by 1%. So we have a lot of work to do, because we should look like the people we treat. And when a population has disproportionate representation of a disease, we're doing something wrong. We can keep saying it's preventable, but we're not doing a good job at educating people about their numbers, about their health care, and we're not getting them to target little things. Treating blood pressure is so easy, you would think. We have so many medications out there. It's the leading risk factor in the United States for heart disease. And yet we get less than half the people to goal blood pressure. Where's the breakdown? Like, we should be doing a better job.
I want to go back to the comment about, am I going to get cardiovascular disease based on the color of my skin? I also think it's really important to educate like families. I was at my church one day and we were having, I don't know what the discussion was about, but you know, people also think, well, my mom had this and my grandma had this and my dad had this. And so they think it's like a family history, but it could, your family, someone was like, well, does it run in families? And I was like, well, it runs in families, but so do behaviors. So you also need to think about if, just because your mom and your dad and your aunt and your grandma and everybody else had whatever, doesn't mean that you have to get it also. And so I think it's important for us to understand that our behaviors are, can be really important in our health outcomes, and to understand that, and then to try to, be encouraged to make some of those changes, because small changes can make a difference. And I think, you feel like, oh no, I need to go and I need to work out for an hour and a half every day and blah, 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 to do all these things. And I have to eat like this much food, and, but you can make small changes that really can make such a big difference, especially over the long haul. And so that's just I just wanted to make sure that we thought about that also, because I think that family component is really strong, and and our perception of what's happening is strong in there also, not necessarily that it's, like your genes, but it, could just be your behavior. And even if it is your genes, your behavior still helps, or hurts. So.
No, I think, Dr. Smith, I love it, because I think it goes back to what Dr. Commodore Mensah was saying about sleep, right? So I do want to go back to the sleep, because I think it's important, but I think the important part that your comment just got us to is it's behaviors, it's care, right? It is also family support, right? It takes a village, right? If you are not cooking your food, then you have to also talk to the person who's cooking the person's food, right? Or if neighborhoods, and this group is always used to me talking about the social determinants, I'm always going to get to the social determinants. If neighborhoods are not safe for people to walk into, how are they going to exercise, even if they know that, or even if they want to, that if I do a little bit every day, if I just walk to the store instead of driving to the store, right? But if it's not safe, people are not going to drive to the store, right? Or not going to walk to the store. If the store that I walk to, we were working with the group of actually Black farmers who, I think this is wonderful that he does this in talking about, and trying to show people kind of food. He walks his students from the most affluent neighborhoods to the poorest neighborhoods, and they go into supermarkets and every single neighborhood and look at the difference. And it's usually kids. And by the time they get, of course, to the poorer neighborhoods, the kids are like, I don't understand why we don't have what the affluent neighborhoods have. Not that they don't want to eat the apple, not that they don't want to eat the fruit. The selection of what available is not there. So of course we know, and I don't want anybody on this webinar, I don't think anybody does, that that there are a bunch of different factors that contribute to this. But that being said, heart disease is the largest killer of folks in the United States, including African Americans. We have the highest rates. And so how do we prevent, right? As we work on these other policy issues, as we work on the social determinants, for those who are at risk, how do we lower risk? How do we prevent? As Dr. Gulati talks about, and how do we help once it happens? How do we help people survive? Because you can survive with heart disease, right? You can survive a heart attack. You can survive these issues, but it's making sure people get the right help. And so I do want to talk a little bit about this aspect of prevention, treatment, and I guess you call it survival or control is probably the best way. So I want to start with Dr. Commodore Mensah, and this idea of sleep is one of them, and that could be a preventive measure. Yeah.
Absolutely. So the American Heart Association recently added getting healthy sleep as one of those behaviors as part of what we call the Life's Essential 8. It used to be Life's Simple 7, but we are finally acknowledging that not getting adequate sleep is linked with poor heart health or getting too much sleep. So both ends of the spectrum. Yes, most people are like surprised that if you get too much or too little, is linked with poor heart health. But we know that sleep is important because when you do sleep, that's when your body recovers, recuperates. And if you're not getting enough sleep, and I think all of us can reflect on the time that we woken up in the morning with only 4 hours of sleep, what happens? We make very bad decisions. We don't feel well. We eat foods that we think are going to make us feel better, but make us feel worse. So getting healthy sleep is important. And the American Heart Association has a number of resources that talk about ways that you can get better sleep. I think one of the reasons why a lot of people, or us, I'm going to include myself, may not get enough sleep is what? Our phones. So what can we do? Put the device away. Do not charge it next to you. So some of these practical steps in terms of not robbing yourself of that time for your body to rest and recover. So that's definitely one of those things that a lot of us do not acknowledge, but it's linked with heart health. But you also talked about control, and I just want to share, this happened just this past Sunday when we were in one of the churches as part of the Engage with Heart program, and we screened people for heart disease risk factors. And I had an older woman in her late 60s who walked up to me. We were going through her numbers, and she said, I used to be 170 pounds. And she said, well, I've made drastic changes. She told me about how she now walks almost every day. She avoids fried foods, and she had diabetes at a point. But because of the lifestyle changes that she made, she lost about 40 pounds. And guess what? She no longer has diabetes. I love to share those stories because it's very easy to think, I have this condition, I have it for the rest of my life. But diabetes is one of those conditions that, as a result of obesity and behaviors, you may develop it, but with lifestyle change, you can actually reverse some of the damage that is done. And even if you're diagnosed with cardiovascular disease, it's never too late. Even in your 50s, 60s, it's never too late to change your lifestyle to reverse some of these processes.
Dr. Gulati, can you talk about a little bit, what do you do with your patients when somebody presents to you with either cardiovascular disease or they have risk factors? How do you help them out? How do you navigate them through that process?
Well, the first thing is, and just to add on to that prior discussion, is everyone should know if they're at risk for heart disease. And I think that many people don't know. They are not told, even when they get a diagnosis of diabetes or hypertension, nobody says to them, this is a risk factor for heart disease. And we need to be better at our health education of our patients. And so for the people that are just patients out there, which we're all patients at some point, you know, the most important thing is to know your numbers. It's not good enough if your doctor just says your blood pressure is normal. What are the numbers? What is my number? Because for women, we all remember as we were younger, we were told our blood pressure was really low. And then as we get a little bit older, of course, our blood pressure goes up. And it's good to know that it's going up, because sometimes patients are shocked when we say, now your blood pressure is 150/90. And they're like, no, no, no. When I was pregnant, I was told it was 90/40. I mean, I had a low blood pressure. And you're like, yeah, that was then, this is now. But you know, nobody's given them the in-between. So I want you to take away to get your numbers. Know what's normal. Normal blood pressure these days, based on our guidelines, is blood pressure 120/80 or under. So if you're above that, it doesn't always mean you have hypertension, but if you're above that, you're at risk for hypertension. And there's a threshold where we now call 130/80 hypertension. So at that point, you may need just lifestyle changes. As it gets higher, you may need medications, but you should know where you're at. Cholesterol too, as I think one other speaker here had already said, people are on good cholesterol, bad cholesterol. We should be breaking it down for you. As part of your visit, I feel like what I do a lot of is hopefully empower my patients to take control. Know what your total cholesterol is, because that's how so many people talk. But then I always tell them the most important number out of all those numbers is your LDL. And I have a different goal for LDL for everyone, and I might give them their personal goal, just in broad, these are broad strokes. Ideally, I love your LDL under 100. If you have heart disease, I like your LDL under 70. And those are just, again, you may have different numbers that have been told to you by your doctor, but just know, at least know those numbers. And you should know what your cholesterol is. You should say, what is my LDL? You should know if you have been screened for diabetes. Have they checked a random glucose, or have they done something called a hemoglobin A1C? And what is that number? What is that value? Is it normal? Is it elevated? Even something called pre-diabetes or glucose intolerance puts you at risk for heart disease. And sometimes knowing that will make you make smarter choices, meaning that, you know, maybe you won't have that extra donut. Maybe you won't always have dessert. You might skip it and say, you know, I need to be watching my glucose. And hopefully we've provided you with some education about, you know, the simple carbs that we need to try to reduce and the more complex fibers to get into our diet. So I think one thing I spend a lot of time on is educating people on what they can do to be healthier. Exercise is always going to, movement though is important. I know when I say the word exercise, a lot of my patients are already checked out. They're like, I don't exercise, I don't like it. But you already heard this beautiful example of somebody walking, and that they may not have even thought of that as exercise. I know what I every day I exercise, but I also walk 3 miles to work and 3 miles home. It's made a huge difference in my own health. In ways I can't even explain, and I'm never getting a car again. We're done with cars in this family. We are a 0-car family, but you know, there's things you can do, things that bring you joy. Dancing may not feel like exercise, but it's just fun. But it's activity, it's moving your body. So many of our jobs are sedentary jobs these days. We are sitting more than ever, and then we come home and we sit, or we commute and we sit, or we go to a meeting and we sit. So just move more, sit less. You know, these are things that we need to do. And I hope that people are talking to you about your diet in a culturally sensitive way. Everybody's culture makes us eat different things. I come from a South Asian culture where we can outdo the Black community in terms of unhealthy foods that are part of every gathering, every celebration we have. And it's trying to teach within someone's culture, you know, the things that we need to eat less of, or maybe just have a taste but not go crazy? Or how can we bake things rather than fry things? Like, we know it tastes better when it's fried. Come on, we all know that. But can we make that a special event and more of our days on the healthier side? And so we need to meet our patients where they are and understand that there's differences between me and my patients every day. And I love learning from them about their culture and about what's important to them. But I also love when we find a place where we both can agree that something can be changed to improve their health. And I know that's a very long answer to your question. It's not even the whole answer, but I don't want Dr. Smith not to have an opportunity for me talking too much. So I apologize.
No, we have plenty of time. I'm actually going to go to you, Dr. Smith, but I do think that's actually a really important example, because I think in plenty communities, particularly, Black and African diasporic communities, rice is a big deal. And I remember my dad, who was pre-diabetic, was going to his doctor, and they were like, you should do 1 cup of rice. And he was like, uncooked. And the doctor was like, no, cooked, right? But, because it fluffs up. But, like, that's how he thinks, because for him, a huge plate of rice is what he doesn't eat in unless he had a huge plate of rice plus plantain plus all the stuff. I used to always joke with him. I'm like, Dad, that's starch upon a starch upon a starch. And he's like, I know, but it's good. And I was like, okay, well, why don't we try half of everything? You know what I mean? And so, you don't want people to not eat their cultural foods. You also don't want people to feel like they're being, they're missing out on things that they have joy. I mean, there's so much going on in the world. We want people to enjoy their lives, but it's just moderation. I always tell people it's moderation is the key. You don't want to exercise too much to the part that you're falling out, but you have to exercise and you have to move. And so I think that's really important. Dr. Smith, your thoughts on this idea, and how does the Jackson Heart Study fit into us thinking about different prevention methods, control, and treatment?
And so for us, I'll talk a little bit about our Community Engagement Center. So it's with our the Mississippi Department of Health. And so they have a variety of programs. They partner with community organizations, with churches. They have community health workers who go out and conduct programs. They have that Brothers program where they go to the barber shops and have now trained the barbers on doing blood pressure. So while the men are, getting their hair cut and, carrying on, chatting, yucking it up. And then they also can get their blood pressure checked and, monitored. And it was really nice because it's a really trusted place in the community. And so they do a lot of blood pressure screenings. And when COVID hit, they also were able to kind of segue and use that to also provide education for COVID and testing and that sort of thing also. So it's really been a really important community partner and community program. They also do a variety of blood pressure screenings throughout the city. They have they work with some of the housing and so so they conduct some programs in some of the housing units also. They recently started one where they were actually giving participant or community people blood pressure cuffs to be able to monitor their own blood pressure at home and show them how to do that. So that they could see how it was going over time. And so they've had a lot of those sorts of programs. What's also really interesting about I'll just say a couple of more things about our Community Engagement Center is that they also do demonstration projects. So they have small projects that are partnered with a community organization to also do work in the community to that focuses on cardiovascular health. And so there was one where they were working with diabetes and trying to educate participants in that program about diabetes over time. And so that was a really nice project to kind of get health information to the community in a way that is much closer to the community, right? So the way it's supposed to work is that they may have an investigator, but they have to partner with a community organization. Sometimes community organizations come in by themselves. And so it's been a very nice mix. And just in full disclosure, you know, this is not work NIH usually does, right? So NIH is not the, oh, and we're going to partner with the community, and, you know, that's not what we typically do. So this is a really novel component of a program, especially a research program. There are some new programs where we are doing a little bit better with engagement of communities, but this has been a long-standing component of the Jackson Heart Study, so that we could make sure we were giving back to the community as we were also doing the research. Oh, there was something else I was going to say. I will have to come back when it comes back. But it's really, so one of the things is that they have to educate us as well. You know, I've been with this program for about 3 years now. And so when they would say, oh, and we're working with our community partners to do X. And I was like, well, what does that mean? You know, and so it's been a very interesting education for me as well, just understanding that how it works and how they work with community partners. And they keep bringing on partners to do more and more work in more of the areas. So Jackson is in three small counties. There's like Hines and let me not call them out because in case I can't remember. But anyway, there are 3 small counties, or 3 counties right there in the Jackson area. And so they also have, but there's most of Mississippi is very rural. And so so the Jackson area is really the most urban part of the entire state. And so what's been nice is that they recently made developed a partnership with a place that's a little bit outside of our regular region, but it's one of the areas that's very underserved. And so they've got some community health workers going there, and they partnered through. It's interesting the way they partner, because they partnered somehow with the library system to access this group, and I guess that's where they do some of their activities, but it was like that was the segue into the community. And so now they have a program where they have community health workers going to help educate community members. So it's really been a very successful program, and and so we're really proud of our community engagement center. It's really been doing great work. And so anyway, I will stop.
No, I love that, Dr. Smith, because I think you're transitioning me into, you got about 20 minutes left. So I do want to ask a couple of follow-up questions, but I also want to leave room for question and answer. So for the audience who's listening, you can use the question and answer function at any time to put a question into the chat for the panelists, and I'll either say it and we'll have folks answer it. So please start doing that now if you have some questions. If not, I got plenty. But I just wanted to make sure that I made sure the audience had the time to ask any questions they have to. So please, if you have any questions, put them in the question and answer box. So I think this important part about community engagement that Dr. Smith just started talking about, that we all have been talking about, is so on this call, as I explained to you all before we started, but it's important to know that we have members of affiliates across the country who are in the community, working with communities at all time. They're doing housing counseling, they're doing insurance enrollment, they're doing economic development work, they're doing workforce development work, they're doing all they're interacting with clients all the time. What is it that you would want them to know and we're not asking anybody to diagnose, so nobody's going out here to diagnose. But if you wanted them to be able to provide this information to the folks that they see and the folks that interact with, they're also doing COVID-19 vaccine. Let me not forget that we do a lot of work on COVID and getting people vaccinated. How do we help them to get this message out to the community about heart disease and its impacts, and why it's important for people to pay attention? And in particular, I want to go back to a question I was going to ask before, is really thinking about the risk factors, because I think when people think heart disease, they always automatically think a heart attack, right? And the only outcome of heart disease is not just a heart attack. It's one of them. It's the biggest one. It's the one, it's kind of like the cancer example. It's the one that we know and it's preeminent. But diabetes, cholesterol, high blood pressure, obesity, all of these other risk factors can lead to heart disease and negative health outcomes and death. So how do we get our folks, or how do we help them to advocate and work alongside the clients they serve and the communities they serve, and thinking through how we can prevent and reduce the disparities in cardiovascular disease? Anybody can take this.
Well, I'm glad we're getting to this point of just delving deeper and talking about some of these structural factors, because when I started doing this work, I would talk about, eating healthy, exercising, taking medications, but we know that really the root causes of these disparities are structural in nature. And so now when I do talk about heart health, I also talk about the importance of advocacy and voting for better leaders and being civically engaged. At the local level, if there's a healthy kids meal bill, we need to show up. We need to empower people to show up in their numbers to advocate for better access to foods. So even in Baltimore, when I visit some of the churches and we talk about the importance of a healthy diet, and you hear from the congregation, we don't have a grocery store within 5 miles, right? So how do we engage and hold our leaders accountable to ensure that people have access? And when we talk about access, it's not enough to have health insurance, but we know that there are people who are underinsured, or you may have health insurance, and then you have to wait 3 or 4 months to see a provider. And what happens in that stretch of time? And for hypertension, we know is a silent killer. So if you have hypertension for months and sometimes for years, people don't engage. And so I also like this connection with community engaged research. How do we meet people where they are? Because there aren't enough providers, there aren't enough cardiologists, there aren't enough nurses. How do we bring more people into the healthcare profession, including community health workers? How do we engage with other allies to bring everyone together to advocate for better policy? So that is also a passion of mine, which is to encourage people to be civically engaged, to keep leaders accountable, but also add our voice to issues that are related to housing, because housing is related to cardiovascular health. When it comes to finances, having a job, like all of those factors are linked with heart health. And so our voices need to be the loudest as healthcare professionals, but just as a society when it comes to promoting heart health.
And I think if I could add to that, I think that those are such great points. Similarly, it's easy for someone to say, go for a walk, go exercise. But if your neighborhoods are not safe, if they're not safe to walk, or they don't even have sidewalks, it's easy to build neighborhoods without any sidewalks whatsoever, or without parks, without green spaces and safety for people. So, you have to, again, as you already said, meet our patients where they are, but we need to be the voices rising up, fighting for the things that we need in healthy neighborhoods. Red line districting in the United States created communities where Blacks live in one area and white people live in another area, and other immigrants, where they're accepted, they go. But that also has resulted in areas of high pollution. Well, what's a risk factor for heart disease? Guess what? Pollution is a risk factor for heart disease. We know your zip code matters. We need to advocate for clean air, clean water, all the things that many people take for granted, but I know in certain neighborhoods are not there. And these are the reasons that we of course need to be educating people, getting people to vote, but also within our own society as a medical and healthcare community, fighting for things that matter to our patients. And if I could just say one other thing that I think is important to this conversation during Heart Month, another crisis that we have that's strongly affecting the Black community is maternal mortality. Women getting pregnant, if you're Black, it's a hazard, it's a danger. I would be scared too. High mortality for Black women. And it has nothing to do, to be honest with you, with your income. You could, easiest example is Serena Williams went through this near-death experience herself. And so that group, we need, there's a lot of reasons for why Black women's health is at risk. Some of it is due to racism. Some of it is also due to our healthcare system and us not having only Western country in the world that does not protect a woman's rights and give her time after pregnancy, maternity leave, but also healthcare. You get one visit after you deliver a baby if you're lucky. And for many women, if they have to work, they even miss that one. Over 40% don't even make a postpartum visit. So we have a lot of healthcare reform to do if we really want to talk about reducing maternal mortality. Otherwise, to me, it's just a tagline that everyone's going to talk about, and it's just going to continue to get worse.
And I think it's important to note that there are many women who become diabetic and hypertensive during pregnancy, and sometimes it is resolved by the pregnancy, but many times it's not. And so then you have now people with a risk factor for cardiovascular disease who are not being cared appropriately. And so I think that that's a wonderful tie into these crises. And I hope, the people on this call know we've been doing a lot of these. None of these are in silos, right? They're all interconnected. The housing piece, the neighborhood piece, the workforce piece, the economics piece, the maternal piece, everything is working in concert. You cannot look at them separately. You have to look at them all together. And part of it's because our system, and I appreciate Dr. Commodore, Mensah, and Dr. Gulati really focusing on their systemic issues, right? Including systemic racism, but also how our healthcare system functions. We are a sick care function, not a preventive care function, right? And that is something that we've all been trying to advocate for. Even if you have access to insurance, you may not be able to get a doctor, but imagine those people who don't have access, right? And imagine them trying to find care. And it's usually people who are low income. And so, and stress, we talked about sleep, but stress is another indicator because your body functions differently when you're stressed, and that impacts your heart, right? So it's also for us to think about the stress that society, a lot of us, we talk a lot about, the Black Lives Matter movement, what happened in the summer in 2020, that was a stress on the Black community, right? That increased blood, they have evidence that shows this increased blood pressure across the, across the board. It did all these factors. Those are risk factors for cardiovascular disease. So I think it's important for us to recognize that and to be important about the things that, we're not here to sound morose, right? Like, because it sounds like, oh my God, just living is stressful, I'm going to have cardiovascular disease. But it's important for us to recognize the things that impact our heart and then think about ways to doing different actions. So, Dr. Gulati talked about she walks, I can't believe you walk 3 miles every day to and from work, but taking 10 minutes to walk. If for our sedentary lifestyles, I laugh with my colleagues all the time, as much as I sometimes hate the iWatch because it's tagging everything, but it does remind me to stand at least once an hour, something as simple as that, because I am at a desk all day, of just saying, oh, I've been staring at the screen for 2 hours. I haven't stood, so just to stand and take a walk around the office or take a walk around the block just to get your blood flowing, right? It's those simple things. It doesn't mean you have to go exercise for an hour, but it does mean you have to pay attention to movement and what you're doing. And I think that's what we're trying to talk about and say here is that we have to work on the structural issues, and that's what we're working on. But there's also individual level behaviors and changes that people can make to help. Dr. Smith, I wanted to move it to you.
So, I think all of the previous points have been really excellent, and the only other thing I think I would add is that I'm not exactly sure how your representatives interact with the community, but I would say from our community engagement center, what I would say is that them partnering with community organizations who are already part of the community, I think that really seems to make a big difference. And so I would think about that in a way that then it leverages their trust and the belief and the partnership that they've already built to then, make some of these changes or suggestions or provide information to the communities that we're trying to reach.
And Dr. Smith, can you just tell us a little bit more about why also the Jackson Heart Study, for example, because many people on this call may not know that, one of the biggest heart studies in the US was the Framingham Heart Study that happened in Framingham, Massachusetts, but it was mostly.
No, it was all.
There you go. I was trying to be
Caucasian.
kind. Go ahead.
Oh, no, but it was. It's just anyway. And so Framingham is this huge cardiovascular study. It started forever ago, and they have all of these estimates. Everything you probably learned about cardiovascular disease was probably from Framingham in the beginning. And so so that is also out of the branch that I work out of, Framingham. And we have several other cohort studies also. And so Framingham was in Massachusetts. It was all whites, and they have just been following them for a long time. And now they are following kids. And so Jackson Heart Study is sort of similar in that we are a single site also in Jackson, Mississippi, and we've been following now for almost 25 years. And so it's very similar in that way, that we've been following the participants for a long time. And so we have a lot of measures so that we can look at changes over time. We can see what changes in their behavior or their measures and how that impacts outcomes. So outcomes like cardiovascular disease, like how their diabetes has been going, or how their measures of blood pressure or insulin or glucose have been impacting their cardiovascular health over time. And so now we also, so we're in exam 4 currently. And so we also are looking at some neurological and cognitive measures, because our participants are at about 71, 72 as an average age. And so now we're looking at some of those measures also, because cardiovascular disease also impacts your vascular system, which also goes to your brain and therefore can impact that as well. And so we're looking at some of those measures also. And so it's really been a very fruitful study, just kind of give us a lot of information on the health of African Americans over time. And so yes, I'm pretty excited to be working with it.
Yeah, and one of the reasons why I asked Dr. Smith to be on, because I think it's important for us to know, and I think Dr. Gulati made a good point, that a lot of our studies, the research, the information we knew about cardiovascular disease was based on middle-aged white men, right? They weren't even based on women, and they definitely weren't based on people of color. And so having the NIH, which is our preeminent research institution in the United States, engage in a study like the Jackson Heart Study, where they're following African Americans off of time, is almost like unheard of, right? And really important for us to understand our health, so that we can have preventive measures, or we can have policies, as we've just been talking about, that impact the health of the communities that we serve and the communities that we care about. So I think it's really important for us to understand that work is happening. More needs to be done, but that it's important for us. And I want to go back to Dr. Commodore Mensah's talk about voting. There's a lot of laws out there that are not allowing people to collect data on race, ethnicity, for example. And even though we know your skin color, your race is not a direct biological reason why people are having disparities, we know it's a proxy for, many times, less access to resources, lower incomes, all those kind of things, not by the fault of the people, but by design of our structure and our system. And so that's what race becomes a proxy for. And it's important to collect that data to understand, to see if there are different race ethnicities that are having disparities. So when you start putting bills out there, which unfortunately the Supreme Court blocking affirmative action in higher education, you're now seeing a lot of corporations and organizations who are saying, we can't collect this data. We can't do things based on this. And then that puts us in a unfair. So imagine if now that says, the Jackson Heart Study can no longer go on because it's only focused on African Americans. That could happen. And so that's why it's really important for us to think through and be active in voting and understanding what's happening in the rest of the world, because something you would never think that something from, college admissions at the Supreme Court could filter down to possibly not being able to do the Jackson Heart Study in the future. And so I want us to think through that. So we only have a couple more minutes. Go ahead, Sharon. We don't have any questions, so go ahead.
Okay, I just want to say, so yes, so we have the Jackson Heart Study, and just for full disclosure, we also have other cohort studies. There are studies on Hispanics. We just started a new study on South, let's see, Asian American, South Asian, and Pacific Islander and Native Hawaiian. I don't know the exact name of the study, but we just started one of those. And we have a study that looks specifically at people living in rural populations. We have a women's health initiative, so that looks at women. There's another one on new moms. We do have other studies that also focus on other communities. I just wanted to make sure that was also noted in case, you run into other communities, they can know also.
But that's also important because what I just said is that being able to distinguish and to parse out those who are having disparities and focus programs on them is going to be harder to do, right? Because of some of the actions of higher levels of government. Dr. Gulati, it looks like you want to say something.
Oh, no, I was going to actually add what Sharon just added. There's the Mensah study that's South Asian, and then there's other studies looking at all the things she addressed. But I do think that, again, this is a reason for all of us to have advocacy. We're not going to learn about anyone if we don't start changing, if we don't start fighting that we are a diverse population here in the United States. In fact, we know we're not going to be predominantly white in a few more years. And we really need to understand that, I don't think that it's genetics that's really driving so much of our health. It's often where we live or where we come from or the racism that people experience, et cetera. Or access to healthcare. And that's why advocacy, voting, all the things that we all need to care about actually affects overall health.
So we are just about at time. I want to respect not only our speakers' time, but also the folks on the phone. Dr. Commodore Mensah has been really great at dropping a couple of links. They only went to just so you know, they only went to the panelists, but I just put them in the chat for everybody. And then, so anybody who watches this on our YouTube page, those chats will be available. They'll be in the webinar. So it was some of on the studies that we've just talked about and on American Heart Association, I believe, information. So thank you, everybody. Thank you so much to these wonderful panelists and these wonderful, I love, it just happens to me. I think it's a problem. I'm trying to not do it, but I always end up with these wonderful women panelists. And for joining us today and just giving their insight. We appreciate the time that you've taken to talk to our community, and we hope everybody has a wonderful day. Bye, everybody.
Okay, bye-bye.
Bye.
Thank
for having
you.
us. Thank
Dr.
you.
Isaac, I can also add the other studies and the Jackson Heart Study in the, do you want me to add them to the chat right now, or can I just email them to you?
Email them to me and we'll add them to it.
Okay,
Yes.
that'd be great. Thanks.
Bye, everybody.
All right, thank you. It's nice meeting you both.
Thank you. Likewise. Bye.